Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Dr. Ben Weitz. Thank you so much for joining me again today. Our topic for today is to take a look at the COVID-19 pandemic from the perspective of an integrative cardiologist, Dr. Howard Elkin, especially since we know that COVID-19 affects the cardiovascular system in a significant percentage of patients. We've seen numerous reports that patients with existing hypertension, diabetes, and coronary heart disease tend to fare more poorly with COVID-19. But we've also heard about patients with COVID-19 who end up with damage to their heart, including myocarditis and cardiomyopathy. And these are often in patients who never had any heart disease. And we've even seen reports of younger patients in their 30s and 40s with blood clots and even dying of strokes. We've also heard of some of the drugs being utilized, like hydroxychloroquine, causing arrhythmia. Dr. Howard Elkin is an integrative cardiologist with offices in Whittier and Santa Monica, California, and he's been in practice since 1986. Dr. Elkin does utilize medications and performs standard angioplasty and stent replacement and other surgical procedures, but his real focus in his practice is to employ natural strategies for helping patients, including recommendations for exercise, diet, lifestyle changes to improve their condition. He also utilizes other creative, non-invasive procedures like external enhanced counterpulsation as a non-invasive alternative to angioplasty and bypass surgery for the treatment of heart disease. Dr. Elkin has written a book, From Both Sides of the Table, When Doctor Becomes Patient, that will soon be published. Dr. Elkin, thank you so much for joining me today.
Thank you. I'm delighted, as always, to be here with you, Dr. Weitz.
And I'm sporting my pandemic beard here, and we, as we're filming this, since the topic is talking about patients with COVID-19, I wanted to start off by asking you a personal question. How has this pandemic affected you in your practice?
Well, I think it affects everyone. As far as it's affected me, clearly my outpatient business is down a little bit. Maybe about 20-25%, which is better than most. I've made a real effort to keep us running because so many patients, well, I'm a cardiologist, these are the patients with higher morbidity and mortality. So my emphasis has been to keep these patients healthy and build their immune system so they don't end up being a statistic. So it's changed the volume that I see, but it's also given me a chance to really focus on my own health and basically slowing down and smelling the roses type of thing. So for me, it's actually been uplifting in the way.
Good. Excellent. One more question before we get into the COVID patients is I've heard reports that there are a drastically decreased number of patients coming into the hospital with heart attacks and other cardiovascular issues. And this may be partially because patients are afraid to come into the hospitals because they've been told that, they should stay away, or they're afraid they're going to come into contact with patients with COVID-19. What have you seen in that regard?
You're absolutely correct on this. In fact, studies have shown in France and also Spain, and we don't have quite the data yet in New York, but people presenting with what we call a STEMI, which stands for ST elevation acute microinfarction. It's a term we use for a particular type of heart attack that is basically it's a total blockage or occlusion of a vessel, and we need to get in there right away to intervene in order to save a life and to also minimize the size of the heart attack. Now, the number, it's been reported by the cardiology societies that the number of STEMIs has decreased like anywhere from 60 to 80% in the last couple of months. That's huge. Like I still take call about 2 to 3 times a month, and I'm in charge of the STEMIs when I'm on call. And the first week we had a lockdown, I had like 3 cases. It was very, very busy, and that was like the end of February, beginning of March. Since then, I get almost no calls at all. And that's just, I think, an exemplary of what we're talking about. People are staying home. They're afraid to come in, which, of course, is not a good thing. So we've been warned from the American College of Cardiology that we're going to have an onslaught of cardiac cases in a few weeks because people can't stay home for so long, right? I mean, this is a heart attack. But I think it's fear, and people not wanting to leave their home, So
unfortunately, some of these patients who might have come in with less severe disease now or might come in closer to end-stage disease.
Absolutely. That's my fear. And why I've blogged about it, I've written about it, I've been vocal about it on social media. It's like, we're open. We want to remain open. We want to be there for you as a source so that we don't have to deal with end-stage disease.
And in California, where we practice, even though LA has had more cases in some of the rural parts of the state, our hospital capacity has been not even close to being challenged. So our hospitals now are starting to, I believe they're going to start welcoming in patients for non-elective procedures. So hopefully that will help in that regard.
Right. Our hospital has just released that in the last week or so.
Okay.
That I actually did an elective angiogram on a patient. It wasn't elective. He actually needed to have it done.
Right. A lot of people don't realize. I talk to people about elective surgery and they go, "Oh, you mean plastic surgery?" No, we're talking about a huge number of important medically necessary procedures, but they're just not being done because the priority has been to keep the ICUs open for COVID patients.
I walked into my hospital's lobby yesterday because I had a patient. I was doing a cardioversion, which is when you actually shock a patient's rhythm back into normal. And the lobby was like nobody's there. It's so quiet. I've never seen a hospital so quiet. It's surreal. It's really surreal.
Yeah. So while many people think about COVID-19 as a respiratory infection, it tends to have a fairly significant effect on the cardiovascular system. And in fact, its effect on the heart, the blood vessels, the kidneys, and on blood clotting is often what leads to its lethality. And this distinguishes the coronavirus from other respiratory infections, such as the seasonal flu, doesn't it?
Absolutely. And this is so evolving. A few weeks ago, we thought, I didn't really think about it as a cardiac problem. But in the last few weeks, you're seeing it really is quite a bit of cardiac involvement. In fact, at least 20 to 30% of patients, depending on what you read, tend to have an elevation in troponin, which is an enzyme that we look for to detect injury to the myocardium of the heart. And that's what we measure when people come in with a heart attack, and we follow that, we trend it. So we're seeing a lot of these patients are having elevated enzymes, which does portend a bad prognosis. In fact, the mortality with people with elevated troponin levels, regardless of whether they end up having a heart, it just adds it just adds insult to injury. So if you see elevated troponin, it's not a good sign.
I understand a lot of these patients have elevations of D-dimer, which is related to the fact that they have increased clotting. And I've talked to some physicians who are working in emergency rooms, and they're telling me, I don't know if this is done everywhere, but they're starting to routinely put patients on blood thinners when they are admitted for COVID-19.
Yes, our hospital is doing the same. So a D-dimer is a chemical test, and what it detects is basically venous thromboses, clots. And we're talking like normal level is 0, right? We're talking levels as high as 3, 4, and 5,000, which is unfathomable. You'd never see that before, even in someone that's had a vein clot or a pulmonary embolism. So the numbers are astronomical. And then interventionalists that are doing intervening with people with strokes, they're seeing that the clot is being formed as they're intervening. Actually seeing more clot being laid down, which is, I can't imagine that,
And I guess that's what's explaining why we've seen reports of patients in their 30s and 40s dying of strokes from blood clots. And then we heard about that that actor Nick Cordero, who had several strokes, had to have his leg amputated, and is still having some serious problems after being in the ICU for a considerable period of time. What is going on with this clotting and what's going on in the blood vessels?
Well, we're not quite sure what's the chicken and what's the egg in this case. We know, first of all, a lot of people with end-stage disease, they're intubated, they're in the ICU, they're not doing well. They develop this entity called DIC, disseminated intravascular coagulopathy, and so what happens, you have these, and the end product, it's something called fibrin split products. And they cause all these little small thromboses everywhere, kidneys, legs, everywhere. But that's just part of the problem. That's like end stage. When you see DIC, usually it's seen in people that have sepsis or acute respiratory distress syndrome, which of course is common in these patients. But now we're seeing young people, like you say, with strokes or these thromboses. And part of the problem is we're not quite sure why it's happening, but we know that these people they're saying to themselves, this can't be a stroke. I'm only 30 years old, right? And so they are not seeking immediate or prompt attention, which is really bad, because this is something that's treatable. Just like what I do as an interventional cardiologist, I intervene, I go in there and I do a thrombectomy and I do it and then put a stent in. The same thing can be done in a stroke center, which is my hospital is one of them. So these patients should not be staying at home if they have any sign or symptom of a stroke at any age.
Now, there's been some discussion in the literature how this actually ties in with the breathing problems patients are having, which was originally thought to be typical to acute respiratory syndrome. And now they're realizing it has more to do with low oxygen levels. And some of the data is showing that what's happening is that that iron is being liberated. Free iron is being liberated from the heme, isn't able to hold the oxygen, and the iron group is dislodged from the heme group and is floating free in the bloodstream. And I heard one discussion about this. So if you have more iron in the bloodstream, it turns out our blood, which most people think is sterile, is really not sterile. There's a lot of bacteria floating around in there, but the bacteria are not really active, partially because they need iron to actually grow and reproduce and flourish. And now this free iron is leading to these pathogens in the blood growing and creating toxins, and that this might be part of the process that's leading to sepsis and some of these other, coagulable situations.
I agree on that, and this is kind of new information. We're just really reading about it. Again, it's the chicken and the egg thing. What's happening first? And when I think of sepsis, having been around ICUs for many, many years in my training and also as a practitioner, I think about, usually bacterial infections of any manner or form, and then the end result is sepsis. But you do see it in viremia, and it seems to be common in this virus, in which it's just overwhelming. The body's breaking down, okay? The body's breaking down, and like you say, iron, the heme is being stripped from the red blood cells with the lack of oxygen. It's, we're learning so many things, and people need to understand this virus. It's fickle. It can mutate. It can do all kinds of strange things. We don't have a handle on it, and so, like for example, ARDS. We've known about that. We've treated it for years. Acute respiratory distress syndrome. We see it in any type of bacterial and/or viral pneumonias, but usually it responds well to this thing called PEEP, positive expiratory external pressure. Okay, but now we have found that these people with COVID-19 are not a homogeneous group, and some really don't do well with high levels of PEEP. Actually, it can lead to oxygen toxicity and other problems, and that some of them behave more like high altitude sickness, and some of them may need like like a CPAP machine or different treatments. A lot of them are they're put in a prone position on their stomach, right? Because they can aerate more lungs. It's just, we're tip of the iceberg here. That's why it really is a learning process.
So from a natural perspective, if patients are being given blood thinners when they get into the hospital, if I wanted to do what I can from a natural perspective to decrease my chances of having a poor outcome if I do get infected, does it make sense for me to consider taking a natural blood thinner like nattokinase, or maybe increasing my normal intake of fish oil or garlic or vitamin E, which are, may mildly thin the blood out?
Mm-hmm. Well, that's a great question. So what do we do? Can we do anything prophylactically? First of all,
and preventatively, yeah.
Preventatively, right. I'm not, the study that came out about a year and a half ago that's saying, low dose aspirin in the general population over age 50 really isn't something we recommend.
But that's because it might cause more bleeding.
Right. So, and I've adhered to that principle even before that study came out. So now we have a different thing. I would say, yeah, first of all, I definitely am a firm believer of what some things you mentioned, like garlic,
fish oil.
To me, anybody over the age of 40 and maybe even younger now deserves to be on fish oil. That's like my number one go-to supplement.
And since fish oil is a natural anti-inflammatory, and we know
Absolutely.
part of the acute respiratory distress syndrome where you get this cytokine storm in the lungs, you get a lot of inflammation. Fish oil probably could be beneficial in that regard too. So maybe a simple solution is just up the normal amount of fish oil you're taking.
Right. Ginger, garlic, they're also natural blood thinners. Vitamin E, I usually like mixed tocopherols. So these are all things that we can be doing. I haven't recommended, my big thing is fish oil.
Yeah.
That's a great question because we don't know the answer. Should we just, we don't want to thin it out too much because what if you have to do surgery on these patients or an intervention? Right. Then we got other issues on hand. So,
right.
But it's, these are the questions that really need to be answered.
Yeah. And, I've increased my fish oil and added, one of those supplements that has the extracts from the fish oil that decreases inflammation, the inflammatory response modifiers. And anytime I take fish oil, I always throw in some vitamin E. And the preferred source I've been using the last 6 months is the tocotrienols now, because this data seems to be pretty robust for that. We know that patients with existing heart disease and diabetes, et cetera, high blood pressure, have an increased risk. So what can these patients do prophylactically besides we're talking about the blood thinner thing, what else could they do to make sure that they're most likely going to have the best possible outcome?
And by the way, this is probably the most important question anyone can ask, which is what I've written about, blogged about. First of all, keep your appointments with your practitioners because. And
I should say, besides losing 50 pounds, getting all your getting your blood pressure totally under control, and doing all those things to have perfect health. But what can they do in the short term?
Right. Okay. So. You mentioned it already, so let me just give you a little bit rundown of the numbers. If you have pre-existing heart disease, you're twice as likely to have a negative result, meaning death. Your increase in mortality are doubled. 3 times. You're 3 times more likely. Same thing with diabetes. So diabetes and pre-existing heart disease are your 2 biggies. Kidney failure, twice as likely to die. So. And then the next one is obesity, which is, as you know, about 40% of the American population is obese and about 70% are overweight. So we're not dealing with a healthy crowd to begin with. So and that's what I've been talking about. We have used this opportunity to improve your overall health. If you're hypertensive, get your blood pressure down. I'm really strict on that one because the numbers now are they're incredible. They're it used to be 70 million. I don't know, there's 80 or 90 million people in this country with hypertension. Most of whom do not know it. Most of whom are not adequately treated, at least according to the standards that we're looking for. So it's really
and according to the current standards and the way you see the literature, what number of systolic, diastolic blood pressure constitutes hypertension, and what is the ideal range that they should be in?
Right. I always tell people that the ideal blood pressure, whether you're 20, 30, 60, 80, or 100, is always 120/70. And that doesn't mean I try to get that to everybody, excuse me, but that's the ideal. But the standards now, which have been, present for about a year and a half, is that anything above 130 on the systolic range and above 80 on the diastolic range is considered hypertensive. So if you're 131 over 81, that's considered hypertension. Now, does that mean I try to give that to everybody? That'd be ridiculous because patients would be in 3 or 4 medicines if they see me every 3 to 6 weeks. But I do pick and choose on younger people that are really proactive about their health, people that really want to get the yard. Yes, we will do our best to get that way. There's so much you can do with lifestyle. People think that go straight to medicines. And I don't tend to do that when I see unless the blood pressure is off the wall.
So what are the most impactful lifestyle factors that we can utilize?
Well, it always boils down to diet and exercise, right? It's because most of these patients are overweight, overstressed, and they don't exercise on a regular basis. Same thing with diabetes. For me, an ideal diabetic should be in the non-diabetic range. I have many diabetics that start off with high A1Cs. I get them to being a pre-diabetic. Then I get them below 5.7, and they're really a diabetic, but we've got them very well maintained. And, it can be done. It's work.
What are the most impactful dietary factors, A, for heart disease and B, for diabetes?
Okay.
Why don't we start with hypertension?
Right. Then it always comes up this topic about salt, right? This is an age-old problem that's been going on for years. And if you are a person with normal blood pressure, you do not have to worry about salt. Okay. That's really, it's just unnecessary. If you have blood pressure, hypertension, it really is going to depend on whether or not you're a salt retainer. Now, there's not a test that shows whether or not you're a salt retainer, but if you tend to collect edema or swelling of the ankles, if you're African American or Mexican American, these people tend to have a higher incidence of hypertension. In the Caucasian group, it really depends. I am not overly strict about sodium unless they have heart failure, kidney failure, liver failure, or they fall into those groups. Also, kidney failure is a very big one. You have to be very careful about sodium with them. The average hypertensive, I very rarely give diuretics, which help you get rid of sodium. And I don't super restrict. I just say use a prudent diet. You should.
And of course, there's a balance between sodium on one end and potassium, magnesium, calcium on the other.
Right. People have to understand that sodium is not to be vilified. It's important for nerve and muscle function, and it also helps create balance of the body fluids. So it's essential for life. So I think that's been overemphasized. It's actually been shown. I did a recent reading on this. That sugar, believe it or not, sugar is actually not good for the heart. I don't know if, it's for us in functional medicine, it's not a major surprise, right? But the emphasis has really never been on sugar. In fact, some of these on What's the Health was a documentary that came out a couple of years ago, which is, I won't go into my thoughts about it, but sugar was minimized as far as any mal effect at all on the body. So it's crazy. So back to the preventative stuff that you're saying.
But by the way, the easiest way to weaken your immune system is to eat a bunch of sugar.
Right. And I didn't know this, but in my research, sugar actually competes for vitamin C for your immune system. And so my thing is, why would you want sugar to compete? And why would you want sugar to win? Because it will.
Yeah.
I've had patients who wrote on Facebook, wow, since this pandemic, I've stayed at home, I've gained 15 pounds, and I'm I'm baking bread and chocolate chip cookies. It's like, you serious? So people are doing this. I mean, if you like, I drive by this Winslow Stoner place. I never stop in there, but on the way to work, and it's like, it's packed. Or I was at CVS getting some razor blades about 2 weeks ago, and I just happened to walk by the candy aisle. It's like almost everything's gone. These poor kids are at home because they're not in school, and the parents are probably trying to shut them up and give them candy. Terrible. So those are the kind of things, sugar is very deleterious to your health, and it's the last thing you want if you're trying to build or optimize your immune system.
We've been having a great discussion, but I'd like to take a minute to tell you about the sponsor for this episode. I'm thrilled that we are being sponsored for this episode of the Rational Wellness Podcast by Integrative Therapeutics, which is one of the few lines of professional products that I use in my office. Integrative Therapeutics is a top-tier manufacturer of clinician-designed, cutting-edge nutritional products with therapeutic dosages of scientifically proven ingredients to help patients prevent chronic diseases and feel better naturally. Integrative Therapeutics is also the founding sponsor of TAP Integrative, a dynamic resource for practitioners to learn with and from leading experts and fellow clinicians. I am a subscriber, and if you include the discount code Weitz, WEITZ, you'll be able to subscribe for only $99 instead of $149 for the year. And now, back to our discussion. Are there any particular supplements that patients with hypertension might take at this point?
Yes. First of all, I do use, even though I don't normally supplement with potassium, I don't think you normally have to if you eat adequate fruits and vegetables. And, I sometimes will add just supplement with potassium because that can help lower blood pressure, magnesium. So I'm big on minerals. I have a product that has olive leaf extract in it, which has been shown in a population of patients to be effective. It's also anti-carcinogenic. CoQ10 can be helpful. These supplements have small but potentially cumulative roles.
Right.
So I really try to fish oil, CoQ10, those two are must.
Quercetin is a product that it could be potentially beneficial for COVID-19 patients because it's a zinc transporter, but that also potentially can help with hypertension.
Right, exactly. So minerals, there are things you can do. So I add them, plus because of my standing as an integrative cardiologist, a lot of people come to me because they don't want to go on medications. They've been to 3 or 4 doctors. They've all put them on medicines. They've had side effects. They don't like it, so they've heard about me, and they come to me for that reason. So these are the people I like to work with. But it's always going to start with lifestyle, number one. We will add the supplements and do my best to avoid going on medications. Lots of times you need it, because, again, to stay out of the hypertensive range, you may need to add pharmaceuticals. But it's not my go-to, at least initially, unless they're really, really high.
It would be really nice if we utilize this opportunity, if we look at the fact, I'd be curious when we're done with this, if we see how well the American public has fared with the COVID-19 infection compared to other countries. But given the fact that we are, I believe, still the #1 country in terms of rates of overweight and obesity, and I'm sure we got to be close to the top on diabetes, and we know heart disease and is just rampant, as well as these other chronic diseases. We could use this as an opportunity to focus on trying to get our society healthier. And that would be a great thing for the health of our nation going forwards, and would also be beneficial for every other possible reason in terms of lowering our healthcare costs and even making people more productive. I think we should try to seize this opportunity to focus on what we can do to reduce the chronic disease burden.
I could not agree with you more, and I really laud some of the things that you are personally doing. I mean, you have these Tuesday afternoon Zoom sessions that people can dial in, and share the thoughts about COVID-19. And I mean, that is a great move. I've just put together my own supplement, which is really basic, called ImmunoWise, to help boost the immune system. It's very basic. It's got the proper dose of vitamin C and zinc, and I'm blanking now, but it's got quercetin. But it's a nice supplement. Then one bottle, if you take 3 a day, it's going to help with your immune system.
That's great.
So we're doing things, and I'd like to think that a lot of our colleagues are doing the same, taking their opportunity, and also to reassure patients that they don't have to have negative outcomes, even if you have a heart problem.
By the way, I don't know if you just came across the bulletin boards. There's a preprint of a study from hospitals in New York, and they utilize zinc along with hydroxychloroquine. And it turns out that the patients who were taking zinc did remarkably better in terms of being mortality rates and being released from the hospital or not ending up on a ventilator. And the dosage of zinc was actually quite high. They were using 50 milligrams of zinc twice per day. So that's 100 milligrams of elemental zinc. And I think that's kind of interesting that now you have traditional hospitals utilizing essentially a pharmaceutical dosage of zinc and getting incredible levels. So I think it's interesting to see that some of these natural substances can be quite powerful.
And I think this is, again, it kind of why this is such an important learning process. We really don't know. I kind of avoid this whole hydroxychloroquine, Z-Pack thing. We can talk about it. We probably should, because, I see these posts on Facebook and I want to just scream, because these people are obsessed about who's right, who's wrong, why they're right. It's like, you guys, I say,
just make sure when you take your hydroxychloroquine, wash it down with some bleach.
Right. Exactly.
And then inject some Lysol right after that.
Right. I saw this cartoon of our president, but and he was getting getting an enema. Oh boy. So anyway.
So why don't you talk about, hydroxychloroquine or chloroquine? These are drugs that have traditionally been used for malaria, and there are some reasons to see that they may be potentially a benefit. Even though if they are effective, they're certainly not going to be the cure-all. And one of the benefits of hydroxychloroquine is that it helps as a zinc transporter. Unfortunately, it has a lot of potential side effects, and maybe you can talk about that.
Right. So hydroxychloroquine, which has been used for, like you say, for a long time, it's also used in certain autoimmune disorders. Rheumatologists use it for
lupus,
rheumatoid arthritis. I had a patient that was on it briefly for mixed connective tissue disease. She was followed by a rheumatologist at UCLA and had problems. Here's the thing. The success stories are basically very anecdotal. There's a lot of them are observational studies, and I understand it's a new disease, basically. We don't have a lot of data. So, but some people are jumping to, oh, wow, they're using this in Inglewood, a hospital in Inglewood with great success. It's like, okay, I would not take that as gospel. But anyways, so here's what we worry about. It can prolong the QT interval. What is that? The QT interval is something we actually measure on a routine EKG. It has to do with your electrical, it's resetting your electrical activity between beats. So you have a depolarization, electrical impulse, and then the heart contracts. Then it has to relax in between beats for the next one. So it's electrical activity that can be, a certain part of the cardiac cycle can be prolonged electrically as a result of these drugs. We're talking about at least 20% or more of patients on these drugs will develop QT prolongation. Now, if you add azithromycin to it, which is not benign like people think it is, then you're probably magnifying that by double. You'd probably double it. So the two in combination in really prolonged QT interval. Why would you care? Because QT prolongation could lead to malignant arrhythmias. There's one that we look for called torsade de pointe, which means a twisting of the points in French. And I've seen it. And it can be deadly. I mean, this is what can lead to sudden death. So these patients really have to be monitored. Like some people, I've had people ask me, can I have a prescription for hydroxychloroquine and Zinc just in case? Are you serious? As an just in case. I've actually had people ask me this.
Yeah, just go to the pet store and get the kind you use to clean your fish tank with. You see how that worked out for them.
Right, exactly. So
I'm referring to somebody in the news who consumed that, unfortunately didn't have a good outcome.
Yeah. He thought it was, amazing. So anyway, I get another reason to be concerned is because these patients are in ICU. They're critically ill to begin with. Like I said, about 20% of them are going to have elevated troponin levels if you look at the new data coming out. So I don't know. I would not want to give this drug to someone with an elevated troponin level who's already at higher risk of arrhythmias, right? And then you're going to give them potentially worse than that. So these people that are so pro the combination because it works. It's worked. And a doctor in New York, who I don't know this doctor, I'm sure you've heard about him. He said it worked in every patient he gave it to.
I've seen that report too. Yeah. So I'd like to make a couple of comments about the hydroxychloroquine. One is in the functional medicine world, people have jumped on this. I don't know why, but somehow they've, there's people especially tend to be attracted to conspiracy theories, and they think that we have this drug that works, but the medical establishment is telling people not to take it because they want to force everybody to get vaccines. I think it's clear that we really don't know if it might work, and I certainly wouldn't jump on it. And I think there's an alternative. And then number two is there are folks in the natural medicine world who have figured since hydroxychloroquine may be a benefit, I'll just give the patients quinine water. And unfortunately, the amount of chloroquine in quinine water is so low that there's no way, if chloroquine or hydroxychloroquine has a beneficial therapeutic outcome, then the amount in quinine is going to be insignificant. So forget that idea. And one of the main things that hydroxychloroquine seems to do is it increases the ability to get zinc into the cells. They call it a zinc ionophore. And because the cells tend to repel the zinc. And in this recent study in New York, it turns out that the patients on hydroxychloroquine really had few benefits compared to the patients who were taking hydroxychloroquine and zinc, which really what that study shows is that zinc is a real benefit and that hydroxychloroquine is just getting it into the cells. So those of us in the natural world use 250 to 500 milligrams of quercetin each time you take the zinc, and that's a natural alternative to getting the zinc into the system. And then one other potential benefit to hydroxychloroquine is it once the coronavirus gets into the cells, it tends to it gets put into an endosome, and then it gets pushed out of the cell where it could spread, and that endospore requires an alkaline environment, and the hydroxychloroquine creates an alkaline environment. So it may suppress the ability of the virus to spread. But there's a natural agent known as Chinese skullcap that can also do the same thing. So you can combine quercetin and Chinese skullcap with zinc, and you're probably going to get the same benefits without having any arrhythmia.
That's interesting. That's new to me because I'm familiar with skullcap. It's an actual anti-inflammatory, but I've never seen it in that context. But it's interesting though these and like you say, I think
that was pointed out to me by Dr. Peter D'Adamo from the Eat Right for Your Blood Type, who I did a podcast with a few weeks ago. I wanted to ask you about one more set of drugs that are used for heart disease. So we know that this novel coronavirus, they say it's novel because we don't have any immunity to it. So this coronavirus tends to attach to and gain entry into our cells through ACE2 receptors, which are found in the lungs and virtually on almost all the tissues of the body. And so there's been some speculation that certain common drugs for hypertension, like ACE inhibitors and angiotensin response blockers, might increase the risk of worse infection. What's your perspective on this?
Good. I'm glad we mentioned that. First of all, so there are there are ACE2 receptors in the lung, in the heart, in the myocardium, in the kidney. I mean, they're all over. But that's also probably why they work, why they're so effective in blood pressure. But so this started off with an observational study, and I don't even know if it was in vivo or in vitro in China when they noticed this. And it does make sense, right? I mean, if it's the same portal of entry, the virus enters the cell by attaching to an ACE2 receptor, does it make it worse? And then the big thing about that is that, okay, well, ACE inhibitors and ARBs are the most commonly used agents for hypertension. And it's certainly in my practice because generally you can do them once a day, and they're well tolerated with very little side effects. They also have utility in heart failure and renal conservation, people that are diabetics, so we use them a lot. To take all these patients off without any real evidence that they're bad could really make matters worse, because that's what we don't want is more heart disease or kidney disease. So the American College of Cardiology and the American Heart Association, I think, have both come out with statements saying, there's no real evidence that it does make it worse, despite the theoretical information that we have. Some people say, I know you've read about this, there actually may be some improvement.
Absolutely. And you can think about that, right? If the ACE inhibitors are blocking the ACE, receptors.
Exactly. So, I have not taken anyone off of an ACE or an ARB as a result of this information. I've had many phone calls, I've heard about this, but I have dissuaded them from changing. Because when you change blood pressure medications and let's say you have something, a combo that's working, you got to start all over again with a different class of medications.
And the worst thing you want is out of control hypertension, and then get infected and,
right.
have to deal with more problems.
Right. Or heart failure or worse than kidney failure.
Exactly. Exactly. Okay. So I think those are the main topics I wanted to cover. Is there anything else you wanted to tell the listeners and viewers?
One that's interesting. I don't have the answer to this, but I want to hear your opinion as well. This whole thing about testing,
Yes.
Should I be tested? Should I not be tested? And then you've got, again, the same kind of protagonists, antagonists in the social media world saying, oh no. So what we look for, and I want to really get your opinion, is we want a test to be 100% sensitive and 100% specific.
And that doesn't exist in the real world.
Doesn't exist in the real world. So if I am a true negative, that means I definitely don't have the disease or never had it. Or if so there's loopholes. And as far as testing is concerned, it does not clearly confer immunity, and we don't know how long immunity really will last.
So are you now talking about antibody testing or virus testing?
Yeah, okay. Not so much the nasal swab. We know the nasal swab will be, if the nasal swab is done correctly, and these centers know how to do it.
By the way, it was just approved, I think either this morning or yesterday, using saliva, a home viral test using saliva where the patient spit into a tube and send it in. It's been tested in New Jersey for a couple of weeks now. That was now approved as a new way to test, and that's going to be a game changer for, we don't have to worry about having enough for the swabs. It doesn't require the same reagents. You don't have to have somebody in a hazmat suit, with full PPE, worried about sticking the swab down someone's nose and it being uncomfortable and everything else. So as far as testing for the virus,
you got to go way up there.
Yeah, this is going to be a big game changer as far as that goes.
So the antibody testing, it's, there's no perfect test. If you're going to have it done, and I did have it done, you want to check, even though I don't think there's anything that's truly FDA approved yet. I'm not, but that takes a while to happen. Okay, you're not going to FDA approved.
Well, what's been happening is there are tests on the market that haven't gotten any recognition at all, but there's somewhere around, 80, 90 tests, maybe more on the market that have been given emergency approval by the FDA,
Right.
meaning, hey, you guys have some data. It looks like, you guys have done some thorough testing. We don't really have time to investigate, all the details, but go ahead and put it on the market. It looks like you guys are doing a good job to start with. And so I would certainly use a test that at least has emergency FDA approval.
Right. So I chose one that does both IgM and IgG, and it's quantitative. So my test was negative. I maybe will repeat that in 3 months. There's no set pattern how often you should do it, but so we don't have the answers. There's no perfect test. There probably will never be a perfect test, but we will learn more about testing as we learn more about this virus.
Well, there's 2 types of tests. There's one test where you prick your finger, and it's called a blood spot test. And then there's tests where they take serum. And the serum tests are decidedly more accurate. So the blood spot tests are somewhere in the 50 to 70% rate of sensitivity and specificity. And whereas the companies have done a good job with the serum tests are somewhere in the 90 to 100% range.
Correct.
So I would go with a serum test rather than a blood spot test. The blood spot tests are the ones where you get the results in 10, 15 minutes. The serum tests, unfortunately, you have to send into a lab and get it back. But I'd like to make a comment about whether antibodies are protective. Now, it's good to be cautious. It's good to be careful. It's good not to get ahead of the research. And it's easy for people to extrapolate, make all kinds of claims that aren't accurate. So I applaud the medical establishment for being very careful and saying, hey, we don't know for sure if antibodies are protective. But we know that the way our immune system fights against viruses, any virus, is to create antibodies. And this virus is in many ways similar to other viruses. And we know that that our bodies do mount antibodies. And for the most part, not 100%, not in everybody, but generally speaking, I'd like to say that I think if we look at the preponderance of evidence, even though we don't have 100% proof yet, antibodies are going to be protective. That's the way our body works. If antibodies were not protective, a vaccine will never work. Nothing's ever going to work. Herd immunity won't work. The whole point of herd immunity is everybody builds up antibodies. A vaccine is to synthetically stimulate your body to form antibodies. So I know everybody's being cautious, and that's fine, but I'm not saying I have proof for this, but I think methodologically it makes sense that antibodies are going to be protective. The proof we do have is that they're using convalescent plasma therapy, which is taking antibodies from patients who've been infected, and we're seeing really good results. Also, they did a study with rhesus monkeys, and for antibody production, I guess rhesus monkeys are fairly predictive. And they gave the rhesus monkeys the coronavirus, the COVID-19. They tested positive. They got over it. They tested negative. Then they reinfected them with COVID-19, and they did not get infected again because they had the antibodies. And so I understand we're being cautious about making these recommendations. And I think it would be foolish for somebody to say, hey, I had a positive antibody test. I'm going to run around without a mask and infect everybody else and not worry about anything else. Because we can't say 100%.
It's like having these COVID-19 parties. I agree with you. I might want to.
I think for the most part, we should think that antibodies should generally be protective. Don't you agree with that?
Absolutely. And it always goes back to your immune system. People think, they want to think, and I'm not going to try to politicize this by any way, matter, or form, is that a vaccine is like a magic bullet, a magic pill. Americans, we always want that magic pill or bullet, which doesn't usually exist. Now, vaccines can be effective, but you got to remember if you look at just the flu vaccine, the flu vaccine, about 50% of people don't respond favorably to it. Why? Because they're obese, diabetic, hypertensive, heart disease, renal failure, and they can't mount an adequate immune response. When we give you a vaccine, we're really giving you the antigen. We're giving you an attenuated form of the virus. We're dependent on your body to form antibodies. And if your body isn't healthy, you're not going to have the same response. So it still boils back to lifestyle, the kind of stuff that you and I talk about all the time.
Absolutely. Excellent, Dr. Elkin. I really appreciate it. I enjoyed the discussion. For those who don't know, Dr. Elkin's on the west side in my office on Tuesdays. And I believe you are probably the only integrative cardiologist on the west side of LA right now. So patients should take advantage of the ability to see Dr. Elkin in Santa Monica. And I also wanted to say to our listeners and viewers that in addition to this podcast showing up on Apple Podcasts, where if you give me a positive rating and review, I would really appreciate it. But it's on Spotify, it's on all the other places you get podcasts, and there's also a video version on YouTube. And also, if you go to my website, drweitz.com, you can find complete transcript and detailed show notes. And then how can listeners and viewers get a hold of you, Dr. Elkin?
Best way is probably through my website, www.heartwise, HEARTWISE, I'm also on Facebook at Heartwise Fitness and Longevity Center. I'm also on Instagram. So I'm all over social media. So I'd be glad to meet anyone. Be a pleasure.
Excellent. Great. Thank you. I'll talk to you soon.